I would be happy if we can start with you, speaking of you, how you came to psychiatry, and then
Yes,
from psychiatry to
sure.
sexology or both. Then your interest in behavioral and cognitive CBT applied to sexual and relationship
Sure.
issues. Then
Sure.
your view about EFS, and then your view between EFS and WAS. So if we
Okay.
can, those four topics, if
Okay.
we can take about 5 to 7 minutes.
First of all, thank you very much for making this interview. That's very kind. And I'll very honored and happy to talk to you and to the WAS group as well. Actually, my story with medical school started when I was a footballer. I was a football player. So the main football player chose us for the national team and for the most popular team of Turkey to play football. But my father said either me or football. So I chose my father. And since then, I love my father. And I went to medical school because I was told that I'm not capable to go into a place where, as a football player, I was not expected to be able to go to a medical school or a law school. So it was just like a kind of challenge for me. So I did the challenge, and actually I was in the first 50 students of Turkey. So I went to medical school. But when I went to medical school, I started asking myself, what am I doing in here? Because this was not my expectation. And then the only field where my life view and my job meets was psychiatry. I found that when I was in the second year of the medical school, and I thought that I should go into psychiatry, hoping that I will do what I had in my mind, in my imaginations and so on. So I went to psychiatry, but when I started my postgraduate training, the field of psychiatry was dominated by pharmacotherapy and by psychodynamic-oriented psychotherapy. Well, the new and effective pharmacological treatment were very welcome, but there were a few problems with it. One of the problems was once the medication was stopped, there was this relapse. So a relapse was kind of a main problem that was caused by the medications. I mean, they were fine to treat the client sometimes, especially in severe disorders. But once the medication was stopped, all the symptoms came back. That was one of the reasons. Another pitfall was that because, I always believed, and I still believe, that patients should not be passive recipients of the treatment that are given to them, but should actually be active participants of the therapy that has been used in order to increase their self-efficacy, because self-efficacy is very important. And if you give a medication, people swallow and wait for the change to happen. But if you do something for yourself, your self-respect, your self-confidence, your self-efficacy increases. So I thought that I should go into a field where I can involve the people being part of the treatment given to them. So coming from a background, which was medical, I thought I should base my practice on evidence-based approach. And therefore I started a search for an evidence-based therapy with high effectiveness treatment outcome. First of all, it must be high evidence theory, and then on that sound theory, we should apply our treatment methods, which are shown to be cost effective. So on those times, unfortunately, cognitive therapy was not popular and cognitive therapy was not very available. So I started with behavior therapy. The merging of behavior and cognitive therapy became later. That happened in the beginning of 1990s, but I'm talking about 1980s, beginning of 1980s. So on those times, behavior therapy was popular, available, especially in England. So I just applied for a British Council fellowship, and I was succeeded in that exam. And then behavior therapy seemed appropriate to me because it was emerged. It had emerged as a discipline that challenges the theory of psychodynamic therapy. Plus, it was shown to be highly effective. And I was one of the lucky, very lucky clinicians to be able to work at the Institute of Psychiatry London, which is now called the King's College, where I had the chance to work with one of the pioneers, one of the masters of behavior therapy called Isaac Marks. And on those times, again, I had the chance to meet and to work with, remember Keith Houghton? He had written a book called Sex Therapy. It's a classic one, which is one of the first books ever published. And then I had the chance to work with Dr. Crow and Padmaldu Silva, who has now passed away. And Dr. Crow, Michael Crow, was also one of the pioneers in combining the cognitive therapy approach, the couple therapy approach with the sex therapy approach. So we were working over there as registrars with someone called Dinesh Bugra, who later became the president of the World Psychiatry Association. To be honest, I am grateful to those people, and especially to Padmaldu Silva, who has now passed away, for making me move towards being a kind of scientist practitioner. You know, you base your practice on science. So I call them scientist practitioners. And indeed, it was a great honor for me to be the recipient of the Gold Medal Award. You had received that as well, in the year 2014, with Professor Dr. Michael Crow at the Congress, which was jointly held by EFS and ESSM. So it was a great honor for me because he was my tutor. I chose CBT, to be honest, because CBT is an evidence-based approach, and a large number of controlled meta-analytical studies have demonstrated its effectiveness in a wide variety of mental disorders. And the strongest evidence exists for treatment of anxiety, anxiety disorders, and depression, which are very often comorbid to sexual problems. And they are also shown to be very effective in relapse prevention when compared to medication or pharmacological approaches. As you know, one of the major problems of sex therapy is that it is not yet evidence-based in many of the areas due to lack of research, not because we're not effective, but there's a lot of lack of controlled studies who is not available, which are not available at the moment to show its effectiveness. And another advantage with cognitive behavior therapy, because on top of behavior therapy, I was lucky to learn cognitive therapy later on from the masters, from the pioneers of cognitive therapy, like Dr. Beck in America, like many other people, Robert Leahy, like Arthur Freeman, and many other people, and couple therapy from a person called Frank Dattelio. So I had the chance to work with all these masters, and they have over time became my very good friends. And another reason that I chose CBT was because it was a relatively short term, goal-directed, and problem-focused treatment, which is very important. So it was up to the point. It's a kind of disorder-specific treatment, which means when we say disorder-specific treatments, we mean that CBT therapists, all of us have worked over the years to find the key cognitions which lead to the emergence and maintenance of psychological disorders. So once you find the key elements, you work with the key elements, you find if you change the key elements, then the progress of the disorder changes. So it is like a key, really. I mean, yes, when the door is locked.
And it goes beyond the disorder itself. It's more global and more holistic.
Exactly. I think I'm going to come to that point because, you know, people generally assume it to be different than what it actually is. You're exactly right, because people have their own prejudice. Depends on who does the therapy, of course. You're exactly right, because over time, CBT was the mother for lots of what we call nowadays third wave therapies, such as metacognitive therapy, such as mindfulness, such as dialectical behavior therapy, such as compassion-focused therapy, and so on. And treatment strategies, one of the best things is that the treatment strategies were manualized for research purposes and for establishing guidelines for good adherence to treatment protocols. So the reason it was manualized was that people can use it in the research so that they are doing what they're supposed to do and they are adherent to these protocols. So it was one of the manualized treatments, which also gives them some kind of features, which is unique. Well, they don't know me very well. I mean, let's put it this way. When people see me, when I'm seeing a client, let's say that there are students who are watching me, registrars who are watching me, or when I'm doing supervision, you know what kind of things I hear? They sometimes say, this is not the kind of CBT we used to know. This is not what we call CBT. Others call me systemic therapist. Another one calls me existential. Some people, as you said, call me, you're doing brief psychodynamic therapy. But I'm not interested in what I am. I am more interested in what I am doing. And what I'm doing depends on what the client needs. So in that sense, I think, as you said, if you are doing a rose is a rose is a rose, as Shakespeare. You know, this is, I think, not good at the moment, so I took it off. As Shakespeare says, as rose is a rose is a rose. I mean, whatever you call, it's the same rose, as long as you give the rose. So I think in that sense, yes, they call me a CBT therapist, but what I'm doing might be different. There are things that make me a CBT therapist. I teach them Socratic questioning in order to let them find out the answers to their own questions. As you know, Socrates has done this. You know, Socrates was not a person who directly answered the questions, but helped their students to find the answers to their own questions. So we use that nowadays. We don't call it questioning because the word questioning does not sound very well, but we call it cognitive dialogue. So it was a kind of cognitive dialogue. And I give them homework in between the sessions in order to turn information into knowledge, because information is very dry.
You speak a lot of suffering, but if we try to move how you apply these ideas to sexuality and to pleasure, what would you do, you know, and how would you deal with pleasure in a different way or in the same way as you deal with suffering? Or is pleasure part of suffering?
I was talking in general. So lots of people come to us with suffering. That's the reason why I'm talking about suffering. But it's time to talk about pleasure, and it's time to talk about not only disorders, but prevention of disorders, or improving sexual health and that kind of stuff. So I think sexual. Yeah, keep going.
People come and see you because they suffer from different reasons. And in particular, they suffer because of sex, because of love and relation. You know, it's one of parts of the source of suffering, but it's also the source of pleasure.
Exactly. So instead of having pleasure, they are suffering. So I think if we find meaning in their suffering, we have to learn to help them. And I think most of the time it is very important, because I wouldn't call myself only a sex therapist. I would call myself a sex therapist plus a couple therapist, because I believe that, first of all, it is relationship issues must always be considered when working with couples who suffer from sexual disorders. So, most of the people who come forward to seek help for their sexual problems also suffer from couple problems. And so I think a good therapist must be able to be well-trained both in couple therapy and sex therapy in order to, serve the needs of their clients. And obviously, coping with the relationship issues will also reduce the dropouts and improve treatment outcome. So the aim is to move away from a technician type of therapist into a multi-skill therapist that considers the individual or couple as unique and who tailors the treatment plan according to their unique needs and specialties. So in that sense, remember when we started the postgraduate training, unfortunately, it was generally considered to be inappropriate to offer sex therapy to couples with marital problems, because on those times, sex therapy was isolated from couple therapy. And I had my training in sex therapy, especially in UK. And the reason for that, because there was no concept of sexual health, sexual rights, and sexual disorders in Turkey. So when I came back, I wanted to bring something into Turkey. So I established the first sexual health and sexual disorders unit when I came back. So, and I think I was lucky because I was able to work in a institution where couple and sex therapy was combined. As I said before, it is generally considered inappropriate to offer sex therapy to couples with marital or relationship problems on the assumption that the treatment will remain uncompleted or most likely to fail due to the relationship problems. But this assumption creates difficulties in daily practice because in daily practice, separating the two is too artificial. Many people come to us with both. Sometimes the couple comes to you and the lady, or I'm talking about a heterosexual couple in here, and when you ask for them to define the problem, one of the partners would define it as a sexual problem, and it's generally the man, and would say, well, we only suffer from this and that sexual problem. Once you sort that out, everything will be okay. And then you turn to the lady, and the lady says, that's funny, because I think our relationship problems is the thing that causes the sexual problem. So what does a sex therapist do in this point? Well, what kind of treatment? Because one asks for sex therapy, the other asks for couple therapy. What does the therapist do? To me, in practice, in daily practice, the therapist does what he knows. If he's trained in sex therapy, he will give sex therapy. If he's trained in couple therapy, he will give. But that is not the 21st century approach, because our approach, treatment approach, must be based on the basis of the preference of the individual or both of the couple. So we need to be equipped well enough to serve their needs, both in terms of relationship and in terms of sexual issues as well. And the reason that why sex therapy and couple therapy shouldn't remain separate from each other are a few. First of all, they are interrelated in daily practice, so it is artificial to separate them. And second, this separation causes many couples with relationship problems to be rejected from sex therapy from the beginning, and that leads the therapist to work on a highly selective group. I mean, people are giving results of sex therapy sessions and so on, but we don't know if they actually suffer from couple problems as well. If you exclude those couples, actually you're working on a very highly selective group like Masters and Johnson, where you have incredible high amount of success because you're actually, remember times of Masters and Johnson, they actually did not involve the low sexual desire. They did not talk about what was the, what percentage. They said that amount failed, but we didn't know what was how they evaluated success. And so in a way, this appealing results attracted many people from different disciplines to come into sex therapy. And on those times, of course, there were two therapists, and also the sessions were made on a daily basis or short intervals, and lots of things have changed. So remember, I think it was 1970s, Masters and Johnson wrote, wasn't it 1970s? Yes, the human sexual inadequacy. And 10 years ago, because of the research was criticized, another person wrote a book or a paper called Inadequacy of Masters and Johnson. So one was talking inadequacy of human sexual inadequacy, and the other was talking about the inadequacy of the methods used. So in a way, I think it is also very important when you combine the two, sex therapy with couple therapy. This saves the therapist from making a critical decision, which is bound by indefinite guidelines about which couples with marital problems are. So I always want to bring those two things together. And that's the reason why I'm always presenting workshops and keynotes on couple and sex rather than anxiety disorders, which I'm an expert on. But I want to emphasize this. And if you go to a couple therapy congress or a family therapy congress, you'll just find out that when you go to a congress for couples and for family therapy, they do not want to involve sexual issues in it. First of all, they are interrelated in daily practice, and it is artificial to separate them. Second reason is that this separation causes many couples with with marital problems or relationship problems to be excluded from the beginning of the treatment either. And that was not good for research, because when people publish research, they just say that this percentage of people improved with the sex therapy work, but we don't know if they have couple problems or not. If couple issues are removed from this, are excluded from this research, then we cannot rely on those research because that's not daily life. So that's the reason why most of the time, comorbidity issues is one of the reasons why research findings and clinical findings don't go hand in hand, because we make lots of exclusions. And I think we cannot exclude marital problems from sexual problems. And also, I think if that happens, then the therapist or the research is going for on a very, very kind of highly selective group. You are just excluding those people who have couple problems, and then you're taking the people who only suffer from sexual problems. That's not part of daily work. So I think that makes the research kind of unreliable. Plus, it doesn't really overlap with our daily practice. And the third reason that they shouldn't remain separate is that it saves the therapist from this critical decision bound by indefinite guidelines about which couples with marital problems should be accepted and which should not. This reduces the need, if we combine the two, that reduces the need to detect marital problems at the beginning of the therapy, which can sometimes be difficult to identify at the initial assessment. Because when it started first, we wanted those people with marital problems or relation problems to be excluded. So they went to take marital therapy, which was kind of funny. And first they wanted them to have couple therapy and then come forward for sex therapies, during which many couples could not manage to stay together. So they had to wait on waiting lists. So that is also was not very good. And there's research and data as the fourth reason that I have, at least in my hand, which shows that combination of sex and couple therapy reduces the dropout rate and increases the efficiency of the treatment. So we have data on that as well, which is great. So to summarize them all, I could say that sex therapy is far more than simple, modern sex therapy techniques or modern sex therapy is far more than simple application of specific techniques in the management of specific sexual disorders. Marital problems or marital or relationship issues must always be considered when working with couples that suffer from sexual problems. Coping with relationship issues will reduce the dropout and improve the treatment outcome. And the aim today should be to move away from a technician type of sex therapist into a multi-skilled clinician that considers the individual or couple as unique and tailors the treatment program according to the needs and unique characteristics of that couple. So a good sex therapist must also be trained in couple therapy.
As far as I can know, this is a major evolution since the Masters and Johnson, because
Exactly.
Masters and Johnson did not, as far as I remember, they did not into account the couple. You needed to be in a couple to be accessible to the therapy, but the couple issue were not explored.
Definitely. That was one of the things which was missing in Masters and Johnson's work. And another thing which was missing was during Masters and Johnson, the hyposexual desire and interest was not yet defined. It was defined later by Kaplan. So they were kind of selective working with the couples, and they didn't tell us about the success rates, but they told us about the unsuccessful couples. And when they referred to success, they didn't tell about the extent of success. 100% is success, 80% is success, 50%. So what kind of improvement was not visible during their time? So their work was very essential and very important, and we of course respect it, but there are lots of things missing.
Yeah.
And then it was other scientific work completed the gaps. So imagine that you're seeing a couple, female and a male. I'm still referring to heterosexual couples. So one of the it can be in homosexual couples as well. One of the partners would come up and say, hey, doc, you know, the problem is only sexual. If you work and sort out our sexual problems, everything will be okay. And then the partner, which is generally the female, would come up and say, oh, come on, it's not sexual problems at all. We have this relationship problem the whole day, and then you expect our sex to be wonderful, ignoring all the stuff that you are not seeing. I've been asking for improving our relationships in the last 10 years, and you don't care, and then you want sex to be okay. So one is asking for sex therapy, and the other is asking for couple therapy. How does the therapist respond to that? I mean, you want to keep them in order to have the relationship or the therapy progress. Of course, you have to get them both involved into the relationship, but their goals are different. So in that sense, I think it's better to be global, handle them both, and to be able to handle them both, then you have to be experienced both in couple therapy and also sexual therapy. In daily life, when that happens, you know, what happens with it, what kind of decision the therapists take, I think the therapists go for the treatment they know of. They don't really go for the goals of the both partners. But if they are trained in sex therapy, they will try to handle the sexual issues initially. If they are more experienced in couple therapy, they will start with couple issues. If they don't know both of them, obviously they will go for couple, because you can talk about couples as long as you like. But you know, when it comes to sexual issues, you have to have some techniques, and you have to learn, I mean, not only the relationship, but you need some techniques to get them improved. So I think this is an issue that needs to be further elaborated and further discussed in the long run. So this is the kind of things that I would like to say about couple and sex therapy.
The EFS, congratulations for being the new president.
Thank you so much, Alain. Thank you. Thank you. First of all, I would like to say that it's a great pleasure, honor, and also a responsibility to be elected as the incoming president of such a great association. And I would like to thank all of the board members for electing me as the president. And also, of course, I would like to extend my thanks to the General Assembly for the approval of this position. I think presidency will no doubt be an exhausting but also rewarding task. The EFS, as you know, is now an umbrella federation that has more than 50 member associations, many individual members, some affiliated members, and also student members. And I think the EFS's mission during the times of my presidency will hopefully mostly cover, establishing stronger links and building closer relationships and collaborations with associations that aim similar goals and values during the time of my presidency. Our ultimate goal, I could say, is promoting sexual health and sexual rights, improving sexual education, and preventing sexual disorders, and disseminating good and ethical practice of treatments, good and ethical evidence-based treatments to reduce human suffering due to sexual disorders, and for those who have been victims of sexual abuse. I think these are the priorities. I mean, I think it's very important. And I would like to underline that promoting sexual health and sexual rights, improving education all around the world, preventing sexual disorders, and also, if we want to treat them, we have to disseminate good and ethical practice of sexual treatments. So I think EFS's mission to disseminate all these basic, let's say, ideas is going to be accomplished by truly international congresses, and which goes once in 2 years with 2 years intervals, meetings, and setting up optimum training standards amongst member societies, as well as our peer-reviewed journal edited by someone called Alain Giami, uh, and also perhaps by our newspapers. So I hope that in the future, when this COVID times is over, or at least we can come together again, and we can touch each other, we can talk, we can meet, and it is not only the scientific part. We also need to have the humanistic part of the Congress, where you have interactions, where you have make good friends and see your old good friends. That I think that's going to happen. Hopefully our Congress will be like that in Aalborg. We are hoping to have a face-to-face Congress instead of an online one. That's a major idea which we had. I mean, we started to have this idea some time ago, and we made some subgroups, and I'm in the education also group of the EFS. And as you know, we have the educators in one hand, we have the counselors, and we have the clinicians.
Yeah.
So of course they need to have the basics, all of these groups. But as you go to the more clinician side, then you need to have more training. So training standards for educators, sexual educators, standards for counselors, and for therapists or clinicians will not be exactly the same, because clinical work needs further kind of skills to be developed on top of the information, while the educators obviously they need skills as well, but they've got to give the information. So it will be basic for all of these groups initially. That's what I have in my mind. And in the long run, of course, depending on the needs of each discipline, we are going to add something new on the menu. Okay, let me just say a few things that I have in my mind. Actually, we had a EFS meeting just recently, the board meeting, and which was had a different agenda, but I have already mentioned about our interview that I respect very much highly, and I have told everyone that this is a great chance to have better relationships with the World Association of Sexual Health. So one of the things that I have in my mind, and I have shared it with the others, is to have regular meetings. It can be the boards, it can be not necessarily all of the board members, but we should have regular meetings because we are a regional association of WAS, and we need to have regular meetings. And the second thing is most important thing, to make it more attractive, not only for the board members, but for the delegates who are members of both of the association, is to have online activities, hosting webinars together. The third thing, which can be a very important issue that we can do together, is we can have a common press release, such as a joint bulletin. Why can't we have a joint bulletin? I mean, when I was the president of the International Association of Cognitive Therapy, International Association of Cognitive Therapy was associated, that's international, and we have another association called Academy of Cognitive Therapy, which are very popular. So we had a common bulletin, and on the first page of the bulletin, it was divided into two, and the presidents of both associations had their words on it and their goodwills until the next time. The fourth aim would be joint congresses, like the one that we organized with ESSM that we talked about in the year 2014, wasn't it? And which had the highest number of delegates attending. Another fifth important issue is I think we must already have done this, but if it's not done, we have to have links to each other's congresses' websites and things like that. And I think we need to have joint declaration as the last thing, joint declarations. And we have been, we need to have joint declarations. But that shouldn't only be done at the World Sexual Health Day. That could be done on a regular basis. And you can choose mottos that goes towards our aims. I mean, I think the World Sexual Health Day would tell more about our values, but then the kind of declarations we make together from time to time are the goals towards that direction. And as the last thing, and then I can go for your questions if there's any that I would like to say about our declaration, because we had the World Health Sexual Day. Although I was busy yesterday, I had prepared that a long time ago. And our interview has been published in one of the major, actually the major newspaper, and also it has been distributed to more than, 150,000 people, and we are still putting it on our website and so on. But our declaration and was, I think, a very important thing. As you know, one of the main problems, I think we were talking about sexual rights and sexual pleasure, because on the last interview we had, I remember you asking me about, I'm talking about pain and what we can learn from pain and human suffering, and you asked me what about the pleasure. You were totally right, but it's like, how can you have pleasure when the whole world is suffering from lots of things, including political issues? But obviously that's part of life, and obviously we have to have pleasure on top of pain. We shouldn't let pain or suffering to dominate our lives. I agree with you. We have to get pleasure. And I think the role and woman, I think I like that motto which was on the page, and I would add on it, and I liked it very much. Women to be defined for the future with their potential to be productive rather than their potential for child production. This is a very important issue. And I was hoping that women will be more involved in politics and business life to have a more peaceful world. I think these are the things. So I think it is very important to have safe sex, but also have pleasure. Perhaps times of COVID has learned us to get pleasure out of difficult times, maybe increased hot monogamy, or we found some more interesting ways to, or different ways to have pleasure. But I think the most important thing is to really keep sexual health, sexual rights, and sexual pleasure as human rights, and those needs should be well respected, and we shouldn't leave anyone behind. I think these are the last things that I would like to say, but I'm open to your questions.